good evening, everyone. My name is Kirstien Boelaert. I'm an endocrinologist in Birmingham, and I'm also the current president of the British Thyroid Association. A couple of conflicts of interest. So I sit on advisory boards for treatments. These are actually treatments for advanced thyroid cancer. So both for Lilly and ASI. So what I'll cover tonight is a little bit about the epidemiology of thyroid cancer, the way in which patients present, how we diagnose it, risk stratification tools that we use in order to make our decisions with regards to treatments, how do we follow patients up, especially those with low risk differentiated thyroid cancer, in which there's a few changes in recent years. Then I'll just have a few slides on advanced differentiated thyroid cancer, and I will also just very briefly touch upon medullary thyroid cancer. So quite a bit to get through. Thyroid cancer is a relatively rare cancer. Most of the thyroid cancer arise from follicular thyroid cells. So this is, if you take a cross section through a thyroid gland, it'll be filled with these follicles, and these are the follicular cells, and they are the cells that produce thyroid hormones. And so most thyroid cancers or differentiated thyroid cancers originate from these follicular cells. And they are papillary largely, and to a lesser extent, follicular cancers. Anaplastic cancers are very rare, luckily. They're very aggressive, and they tend to be de-differentiated cancers that started off from one of these differentiated cancers that started from here. And then medullary cancers actually arise from these parafollicular cells here, which are cells that sort of lie adjacent to these thyroid follicles. And they are cells that produce different hormones, such as calcitonin. So in most developed countries, in the last 40 years or so, we've seen an explosion of thyroid cancer. So these are the most recent data from CRUK, which shows both for men and women that there's been quite a steady increase in the incidence of thyroid cancer. And in the United States, it's estimated that by the end of 2023, there will be 43,700 new cases and about 2,000 deaths from thyroid cancer. So a lot of this increased incidence is actually because we find more incidental thyroid cancer. So a lot of this is encompassed by very small and low risk thyroid cancers, although there is some evidence that even the larger thyroid cancers are increasing in evidence. So how do patients present? Well, often they present with a swelling in their neck. And so that, unlike thyroid cancer, which, like I said, is in the grand scheme of cancers still relatively rare, thyroid nodules are actually very common and occur in up to 50% of the population. They're more common in women and more common in areas of low iodine intake. And they can present either because we see a lump in the neck, or because someone has a scan and we find one on an ultrasound scan, or because someone has another cancer elsewhere in the body and has a PET scan and it lights up, such as this one here. And so the frequency with which we find this, so if you do a thyroid ultrasound, you have an up to 60% chance of finding a thyroid nodule. And increasingly, because people are having more and more investigations for other problems, such as CT scans or MRIs or carotid Dopplers, you can see here the rates at which we detect thyroid nodules in these. So when someone presents with a swelling in their neck or a thyroid nodule, then we ask three main questions. But what we're focusing on here today is the need that we need to exclude that this swelling in the neck is actually, this nodule is malignant. And overall, when you look at all nodules, the prevalence of malignancy in them is only around 5%. And generally, it's considered that this is independent of the nodule size, although some larger nodules may be more likely to be malignant. There is no evidence that those nodules that we find incidentally, where the patient didn't present and said, I have a lump in my neck, have a more or less risk of harboring a thyroid cancer. But those that light up on a PET scan, such as the one I showed, those are ones that we do worry about because they have a relatively high risk of being cancerous. So are there any other things in what patients report to us that make us suspicious? Well, we know that if a younger or an older person presents with a thyroid nodule, we are more suspicious. If this is something that grows rapidly or is fixed to other structures in the neck, something that's very firm, or associated with a paralysis of the vocal cords, in patients who've had neck irradiation, or very rarely in patients who have a family history. So, and the first thing that we then do when someone has a thyroid nodule, after we've determined that this is functioning normally, so we do a thyroid function test to make sure it's functioning normally, we then do an ultrasound. And there are a number of ultrasonographic features that make it more or less likely for there to be for us to feel more suspicious of a thyroid nodule. So something that's got an irregular margin, that's hyperechoic, that's got a lot of vessels flowing into it, that's got microcalcifications in, that is a nodule that we worry about more. And there are a number of scoring systems currently in use. So the U classification system, and then the thyroids, they are the two most commonly used ones in the United Kingdom. And those features that I showed on my previous slide essentially are depicted here. So it's a combination of these features, and you can see here something, so a U5 would be a nodule where the radiologist says, this is a thyroid cancer. So you can see irregular margins, presence of microcalcifications, lots of vessels in it, taller than wide. So those are all nodules that we worry about. And similarly, a thyroid scoring system is very similar. So what we then do when we have sufficient level of suspicion on a thyroid nodule is that we take a biopsy from it. And here, this picture shows how you take an ultrasound-guided, what we call fine needle aspirate biopsy. So the radiologist uses the ultrasound probe and then sticks a needle in to guide it towards the bit of the nodule that looks most suspicious. And so if they are then rated in a similar to the U classification, it goes from U1 to U5, with U5 being malignant. This goes from Thy1 to Thy5. So Thy1 means that not sufficient cells are aspirated. And unfortunately, depending on the practitioner who does this, this can occur in up to 10% of patients. And so generally what is advised is that we do an ultrasound or a repeat FNA, and the current NICE guidelines actually recommend that in some of these we take a core biopsy, which means that you sort of take a larger sample rather than just stick a needle in and aspirate some cells. So take a proper biopsy from it. Thy2 means this is benign, and then from Thy3, with increasing suspicion, we feel more worried about whether this is cancer or not. So Thy3A means that there are some abnormal cells present. Thy3F means that this is a follicular neoplasm. So this is something that where the cytologist cannot say this is cancer or not. It's a follicular lesion, and the general standard is that this needs to be taken out by removing that half of the thyroid gland, so that this follicular lesion can be investigated fully under the microscope. And then with Thy4 and Thy5, we become increasingly more and more suspicious, and generally certainly from Thy3F onwards, these are patients where we generally do surgery, at least for diagnosis making, if not for therapy. And so if I was asked to give this talk about 15 years ago, it was relatively simple, because all patients with thyroid cancer were treated in the same way. They all had surgery, then they had radioiodine, because however good your surgeon is, you will never remove every last bit of thyroid cell. And then they were told, you are now going to have to go on high-dose levothyroxine, A, to replace the thyroid hormones that you can no longer produce, but also B, because we want to keep your TSH low, because that will prevent further growth of thyroid cancer cells. And then for more aggressive tumors, there were some additional therapies. So everyone was treated in exactly the same way. And patients were told, we will never be able to discharge you. These are cancers that can come back after 20 years. Therefore, you will be under hospital follow-up for the rest of your life, and you will have abnormal thyroid function for the rest of your life. Now, what we have learned is that actually this, or some of these approaches in some of these cancers, especially in the low-risk ones, may actually cause more harm than good. So what I think is good for patients to understand is that there are a number of risk stratification systems. Like with every cancer, there is always risk stratification. So most cancers, whichever organ you're in, undergo a TNM staging. So T stands for tumor, N stands for lymph nodes, so nodes, and M stands for metastasis. So that means the cancer spreading to the distant organs. And for many tumors, this is really good because it predicts death from disease and overall prognosis. What it doesn't take into account is individual treatment responses. So it doesn't tell us how has a particular patient responded to treatment. And it also, in a cancer that has a risk of recurrence, doesn't predict the risk of recurrence very accurately. And most patients, luckily, most patients with thyroid cancer don't die from their disease. So therefore, the TNM staging, we know, is not such a good way of, or not the only way in which we should stage tumors. So the further risk stratification that we do, so once a surgeon has operated on a cancer, we then class patients into low, intermediate, or high risk cancers, and the details of that are given here. I won't dwell on this, but essentially there is an additional risk stratification, and this helps us decide on which patients should undergo radioiodine ablation or not, because unlike what we did 15-20 years ago where everyone had radioiodine ablation, this is now actually a relatively minor group of patients where we give this. This is from the American Thyroid Association guidelines. Again, these are under review, and it's hoped that in the next year or so the new guidelines will come out. But certainly the previous iteration, and what I know many of my colleagues in the United States do, is that they use a similar low, intermediate, and high risk stratification tool for these tumors. And they give a sort of very detailed list here of what things are taken into account. What you can see here is that for some of these, they also take some molecular tests into account. So they are not commonplace in the United Kingdom. But again, there is hope that in the next 10 years or so, we will certainly start adopting some of these molecular tests in helping our decision making. And what we then do is a dynamic risk stratification. So this is very much something that is done 9 to 12 months after the patient has undergone their full treatment, where we take stock of how have they responded to their treatment. And what we look at is whether this has been an excellent response, whether this is an indeterminate, so somewhere in between response, or an incomplete response. And that is based on doing an ultrasound of the neck, where the surgery has occurred, and by measuring thyroglobulin. So the tumor marker for differentiated thyroid cancer is thyroglobulin. So this is a protein to which thyroid hormones are synthesized. And when your whole thyroid gland is removed and every last thyroid cell is out of your body, this thyroglobulin should be undetectable. We also measure thyroglobulin antibodies because they can sometimes confuse the assay a little bit and can make the interpretation difficult. And again, these are antibodies that generally reflect an autoimmunity, but they can be difficult in helping us interpret things. But based on an ultrasound and a blood test, we classify patients into these groups. And luckily, many patients will fall into an excellent group. So they will not have any evidence of any tumor in their neck, and that thyroglobulin will be undetectable. If there is a rise in the thyroglobulin, but not a finding on an ultrasound of finding anything that's left in the neck, that's called biochemical incomplete. And structural incomplete means that there is some evidence that there is disease present on ultrasound scanning. So now in low-risk differentiated thyroid cancer, we are now increasingly recommending that patients don't have their whole thyroid gland removed and that they only have half their thyroid gland removed. So I was also asked to talk about some research. So there is currently the HOT trial ongoing in the United Kingdom, which is actually systematically determining whether this is right. That for many of these patients, we just do a hemithyroidectomy. So these are data here that do give us some hope, because you can see here, these are patients that were followed up for 40 years between 1970 and 2010, who had undergone only half their thyroid gland removed. And you can see that in about 18% of these patients, there was need for further surgery. But when you look at the overall remission rate, so even after patients underwent further rescue surgery, more than 95% of patients after 40 years were actually in remission. So this gives us hope that indeed, by not removing the whole thyroid gland, and therefore causing the patient potentially less side effects from significant thyroid surgery, that we are actually doing the right thing. And indeed, certainly for some very small tumors, so a T1A tumor is a tumor that's less than 10 centimeters. in an increasing number of centers, if they find a thyroid nodule that's less than a centimeter, but that is when on biopsy a papillary thyroid cancer, often what physicians now do is just keep an eye on it. They don't even remove the half of the thyroid gland. Of course, if there are any additional things that make us suspicious, such as radiation exposure or family history or any aggressive features, then you may have to undergo surgery. And of course, some patients do not wish to have active surveillance. And increasingly now, even for those slightly larger tumors, so those that are greater than a centimeter but less than 2 centimeters, again, increasingly a number of centers are doing active surveillance for them. So they don't necessarily take them all out. And I think in the next 10, 15 years, we are going to find out whether that is actually the right approach or not. These are data that will be incorporated in the new American Thyroid Association guidelines, where they looked at all the studies of active surveillance for low-risk thyroid cancer. Most of the data are limited to these very small cancers, like I said, less than a centimeter. And it appears that from those preliminary data that actually this is similar to removing half the thyroid gland, certainly with regards to the number of deaths that they had, the risk of recurrence and other outcomes. But what was found that this was not very sort of consistent data, and that there were a lot of confounding factors, and especially in older patients, further research is needed. So the second question is, do patients need to undergo radioactive iodine or not? And again, for most of those very low-risk thyroid cancers, and so what you see here is this risk stratification that I said, after surgery, you put them into low, intermediate, or high risk. So many of the low-risk cancers, we no longer give radioactive iodine. So that is certainly true for those tumors less than a centimeter, but also for slightly larger tumors, many centers do not routinely give radioactive iodine. Once you go into an intermediate or a higher risk category, then radioactive iodine is still very much used. Now, you can also give radioiodine. So this is what we call radioiodine remnant ablation. So this is to remove every last thyroid cell that the surgeon wasn't able to remove, what we call a remnant ablation. You can also use radioiodine as a therapy. So after patients have had surgery and a radioiodine remnant ablation, if there is evidence that there is still disease present or there is metastatic disease, then further doses of radioactive iodine can be given in those more advanced and more aggressive cancers. A number of studies have also looked at the dose of radioactive iodine that we give. So again, everyone used to standardly get a dose of 3.7 gigabecquerels, but a study both in France and in the United Kingdom have shown that for many of these patients, certainly those lower risk tumors, giving a lower dose of 1.1 gigabecquerels is actually very effective. And if you do that in combination with recombinant TSH, rather than what we used to do was patients are on levothyroxine, they've had their thyroid removed, they're on levothyroxine, and we actually try and make them hypothyroid. So we stop their thyroid hormone replacement for a minimum of 2 weeks. So patients actually do become quite unwell by being hypothyroid. But what this study showed was that giving a low dose and recombinant TSH, that this was a very effective way. And then we've had a further follow-up study published more recently in 2019, where again, the longer follow-up data were very encouraging for these low-risk tumors that were treated with lower dose of radioactive iodine. The number of recurrences were very similar to patients who received a high dose of radioactive iodine. And then last year, a further trial came out looking at giving radioactive iodine or not in low-risk thyroid cancers. And again, this confirmed that it made no difference whether you gave radioactive iodine or not, either for a structural, so this is the regrowth of a tumor that you can find on imaging, or for a rise in thyroglobulin. So it seems that a lot of these low-risk thyroid cancers indeed, giving radioactive iodine is probably overkill and may cause more damage than is necessary. And then the third aspect of this, I told you it was surgery, radioactive iodine ablation, and then TSH suppression, is all those patients who've been told, we need to keep your TSH abnormal for many, many years. And again, so these were patients who underwent a lobectomy. So that means only half the thyroid gland was removed for papillary thyroid cancer. you can again see that the recurrence rate is very, very low, 1.4% during a five-year follow-up period. But importantly, what these graphs here show is that it made no difference whether you suppress serum TSH or not. And the disease-free survival, so the survival rate of patients without having any thyroid cancer was not different depending on the TSH level that they had. And the reason why we worry about this TSH suppression is because we know from both in patients with thyroid cancer, but also outside, so patients who have endogenous low TSH or have a low TSH because they're taking too much levothyroxine, even if they don't have thyroid cancer because they have autoimmune thyroid disease, that this is associated with an increased cardiovascular risk. And so this is a study specifically looking at patients who were treated for differentiated thyroid cancer. And you can see that when comparing patients and controls, that patients who had their TSH suppressed were at significantly increased cardiovascular risk. And therefore, we are a little bit worried whether in those patients with a low-risk cancer, whether by actually suppressing their TSH, we expose them to many other risks, whereas the TSH suppression may not actually be that beneficial. And it is not just the heart we worry about osteoporosis, and we worry about the potential of patients developing dementia. And so this is from the American Thyroid Association guidelines, but most guidelines adopt a very similar approach, where you take additional risk factors of the patient into account, and then also you take the aggressiveness of the tumor into account and the response to treatment. And certainly patients who've had an excellent response to treatment, there is hardly ever any need to suppress serum TSH. And so the reason to continue to do that or to start patients on TSH suppression is in those patients who have a more aggressive cancer, and certainly in those patients who have no other known risk factors. But someone who's in atrial fibrillation, hardly ever we would recommend that they go on TSH suppression, because their risk from dying of an arrhythmia or a stroke or another cardiovascular disease is much higher. And then a further question, and this is very much addressed in the UK consensus statements for low-risk thyroid cancer, but this is also in the NICE guidelines, a very similar approach, is that patients who have remained well after their dynamic risk stratification are in an excellent response category and have been 5 years okay, that we can offer discharge. As long as there is no evidence of recurrent disease, as long as they have a TSH within the reference range, and as long as the thyroglobulin is interpretable. Because like I said, if there are positive antibodies, then this can be very difficult. And again, what's recommended is that it's important to consider remote or nurse-led consultations for many of these patients. I don't know why I can't now move my slide. Just stop sharing and share it again. Do you want me to stop here and ask if there are any questions, or would you like me to carry on and just try and share it? Would you like me to carry on?
I was going to say, I think, yeah, I mean, we've had a few questions come up, but I think some of them may be answered through some of your slides already, Kristien. So
shall I carry on?
Yeah, carry on, and people can continue to put things in the chat, and then we can go through them at the end if you're able to. Just
find my slide where I was and try again from there. I don't know why that suddenly stopped working. This is the one I want. Is that okay?
Yep, perfect.
And it's working again. Right, so this is our proposed algorithm for low-risk thyroid cancers. So depending on, so lowest thyroid cancers are, can then be further divided in patients who've just had half their thyroid out, patients who've had their whole thyroid out and had not had radioactive iodine, and then patients who've had a total thyroidectomy and radioactive iodine. And so what we do is we give advice on how often should patients have their ultrasound. So certainly for patients who've had half their thyroid out and those who've not had radioiodine but had their whole thyroid out, we suggest that this is done at 6 to 12 months and then again at 3 years. it's really difficult to measure serum thyroglobulin in someone who still has half their thyroid gland there, because of course they have half a thyroid gland that will be producing thyroglobulin, and we recommend that there is no TSH suppression, but that TSH is kept in the lower half of the normal range. Dynamic risk stratification, if you've only had half your thyroid out, is not applicable. And for most patients, we recommend a 3 to 5 year follow-up. Patients who've had full treatment but are in the excellent response category, we say do an ultrasound at 6 to 12 months, which you would need anyway to do your dynamic risk stratification, which you would do at 9 to 12 months. And if this is negative, unless there is any specific concern, then it's often not necessary to continue doing ultrasounds, because I think we're getting too many patients with very low risk cancers who continuously are having ultrasounds, and our departments are just completely swamped under it. But so some clear guidance here, and like I said, this is very similar to the NICE guidelines. So I'll just move on then very quickly on some targeted treatments for advanced thyroid cancer. Now, I can give a whole further hour of talk on this. There are a number of treatments available for advanced cancer. So what this shows here are all these various pathways that we can affect. But so certainly new upcoming treatments are sabelcatinib and pralsetinib, but we've also had some other treatments, vandatinib, cabozantinib, and lenvatinib, that can be used in these so this is the other side of the spectrum. So these are the more aggressive cancers that are either metastatic or continue to cause problems. These are targeted treatments, so they work on a particular molecular target. Now, they're not without side effects, and there are a number of common side effects. So lots of people get problem with their blood pressure. Often we have to adjust their thyroxine dosage. That's not a big problem, but people can get quite significant skin changes. So they are not easy drugs to take, and clearly the indication for them needs to be very clear. And often it is patients with metastatic cancer who are very symptomatic, but the patient themselves also need to have quite a good performance status in order to be able to tolerate these drugs, because there are a number of potential significant side effects there. And what we have done recently, so we've written a number of guidelines, but so a guideline on the use of these systemic therapies in patients with advanced thyroid cancer has very recently been published in Clinical Oncology. And then just a few words about medullary thyroid cancer before I come to the more interesting part of the evening, which is you asking me questions. So medullary thyroid cancer, so this accounts for about 3 to 5% of cancers. Like I said, these arise from those cells that lie adjacent to thyroid follicles, the parafollicular cells, and about 25% of these are as part of an inherited syndrome. The tumor markers that we use here is calcitonin, which is the main hormone that is produced by these parafollicular cells. So this is a hormone that's involved in calcium metabolism, but also carcinoembryonic antigen is a further tumor marker that we use here. It was thyroglobulin in differentiated thyroid cancer. So these here are the cancer syndromes that we can get. So it can either be a familial medullary thyroid cancer syndrome, where the only affected organ is the thyroid, resulting in medullary thyroid cancer, but one that runs in families. Then we have MEN2A and MEN2B. And essentially, this is a combination of medullary thyroid cancer, problem with the adrenal gland, which is called a pheochromocytoma, so a particular tumor of the adrenal gland that produces extra adrenaline and noradrenaline. And then also a problem with the parathyroid glands, which are responsible for, again, calcium metabolism and producing PTH. So there'll be screening for these associated syndromes in patients who have a mutation consistent with MEN2A. And so any patient with medullary thyroid cancer, when we diagnose that, they have to have their gene sequenced to see whether they have a mutation in what we call the red gene, which is the gene responsible for these familial cancer syndromes. And you can see here the various mutations. This is a lot of detail that you don't need, but the various mutations that are associated with these various cancer syndromes. So 75% of patients will not have a mutation. 25% of patients will have a mutation. And if you have a mutation, then we'd have to do a whole family screening, and often patients who do have this same mutation will have to have their thyroid gland removed prophylactically and will need to undergo regular screening. So in medullary thyroid cancer, the treatment options that we have available, well, your best treatment option is surgery. And so usually this is treated with a total thyroidectomy. The whole thyroid gland is removed. Often patients present with already lymph nodes present, so they may have more extensive surgery. And then in those progressive patients, additional treatments may also be used. But this is quite a different type of cancer, where up to 17% of patients of patients will have metastasis at diagnosis, and a significant number develop metastasis during follow-up. Calcitonin is our tumor marker here, because once the thyroid gland is removed, you shouldn't have any calcitonin present. And if there is a doubling time in calcitonin, then that is something that we worry about. And also doubling time of the tumor bulk on scanning is a further aspect here. But so patients here are managed by measurement of calcitonin and CAA, which is our tumor marker in this case. Like I said, everyone has to have red oncogene testing and take a clear family history. If you know that a patient has medullary thyroid cancer, before they have their surgery, generally you need to make sure that their adrenaline and noradrenaline are okay. So these adrenal hormones, that they are okay, because they could well end up in trouble during surgery if they haven't been checked. And also at baseline, we would check their calcium and PTH. And then in those patients who have a mutation, genetic counseling will be very important. So it's really important that this is followed up in a specialist setting, that they have annual measurement of calcitonin and CAA, as well as their thyroid function, because most of these patients will have their whole thyroid removed, so we need to make sure they're adequately replaced. But this is not a place where we would do TSH suppression. I talked about calcitonin, doubling time and imaging as needed. And then those patients who do fall in the genetic category will have additional screening of having their adrenal hormones measured, and have additional imaging of the adrenal glands, as well as measurement of their calcium and PTH. And then again, like I've already said this, but quite often younger people may then in the family may need to go under prophylactic surgery if they've been found to have this mutation. So the majority of differentiated thyroid cancers are low risk. We use a number of risk stratification tools that help us. Thyroglobulin is a tumor marker. And I think one of the important things in the last 15 years or so is that the guidance regarding TSH suppression is relaxed. Medullary thyroid cancer, like I said, can be sporadic or hereditary. We have a different tumor marker here, and this is definitely a tumor that needs to be followed up in a specialist setting lifelong. So I will stop sharing now. And there's my screen. Thank you.
Thank you, Kristien. That was great. We've got quite a few questions, but I know that Mike's had his hand up for a while, so I'm going to let him come to you directly. So, Mike, I'm just going to ask you to unmute. There you go.
Yeah, sorry, I've just got a bit by family. Sorry that you can't speak. All right, just basically a question. So with me, so I've had my thyroid cancer.
Yeah, I'm sorry, Mike. I can't hear you very clearly. Can you
hear me now? Can you hear me now?
Yeah, you're quite muffled.
Can you hear me now? Can you hear me now?
Yeah. Do you want to try again?
Can you hear me now?
No, I have to admit your sound is not great.
What about now?
Okay. Do you want to have another try? See if Kristien can hear you.
Let me speak on my...
No. Are you able to?
Can you hear me now? You must be able to hear me now.
Yeah. Do you want to have another try, Mike, and we'll see how we get on.
As I was saying, yeah, I had thyroid gland.
No.
With me.
Are you able to write it in the chat at all, Mike, with your question?
It's all right. I give up.
Okay. Oh, I can see Jenna, you've got your hand up now. We'll try see if this works. Hi, Jenna. How you doing?
You're right there. Is everything okay on my end?
Yeah, we can hear you loud and clear.
Amazing. Firstly, I forgot to take a screenshot of your last slide, just if it's possible to bring that back up just to get a screenshot. And yeah, you spoke. Sorry.
Because this whole thing will be recorded and will be available to you. And
fine.
I'm happy to send my slides to.
It was just that last one. I just went to screenshot it and then it cut off, so I never got it.
Yeah, no problem.
Okay. So you spoke about the parathyroid already.
Yeah.
I just wanted to get a bit more detail on that. My parathyroid's been really high for like a year now, and my cholesterol's really high as well. So I just wanted to get some insight on the correlation with that and how that ties in.
But so this is not in relation to medullary thyroid cancer, or it is?
Well, I believe those are things that have happened because of that, I would have thought, unless you know otherwise. But
so you have medullary thyroid cancer and a RET mutation?
Oh yeah, that's a good point actually. You mentioned it with that one, but I've got the PTC. So does that mean it's not linked?
So it's no, they're not linked, but so primary hyperparathyroidism is a common disease.
Okay.
So if your PTH is high and your calcium is high, then that requires further.
So my bone profile went funny a little bit with the calcium and the phosphate, but it's fixed itself now.
Right.
But my parathyroid's still high.
If your PTH high.
Yeah.
And your vitamin D replete.
I'm overdosed on vitamin D. Yeah.
Okay. Then that needs further attention and evaluation of whether you have whether you have primary hyperparathyroidism. So that's not a consequence of differentiated.
Oh, really?
Differentiated thyroid cancer. So, and I know I spoke a lot of. I try not to make it too difficult, but in order to explain it. So what you've had is a cancer from those follicular cells, a differentiated thyroid cancer. That's generally not associated with primary hyperparathyroidism, but that's a common disease, especially in women like you, women your age. So that needs further attention. Yeah,
I must admit, I've not had luck with endocrinologists. They keep discharging me because my TSH is normal, and it's just been really stressful. But with regards to the cholesterol being high, then you can't speak to that being in relation then, because they reckon it's because of the cancer. So your cholesterol will not be high because of the cancer. Cholesterol can be high in patients with hypothyroidism who are underreplaced, but it wouldn't be high because of your thyroid cancer. Yeah, so my TSH and T3 and 4 are still in just about normal range, but my cholesterol keeps getting higher and higher. But so you had surgery for differentiated thyroid cancer? I haven't had surgery yet, no. Okay, all right. So I'm talking about TSH, keeping that, after patients have had their initial treatment. So are you going to have treatment for different? I'm going to try the holistic route first, and then if it doesn't work, then I'm going to go for surgery. It's difficult to manipulate TSH before cancer has been taken out and before we have the full staging to see which risk category you would fall in for TSH. Oh, okay. Okie dokie. Yeah, it's a minefield, isn't it?
Thank you for your question.
All right, thanks. Cheers.
Hi, Jim, are you there?
Can you hear me?
Yeah, we can hear you, Jim.
Yeah, hi. There's a growing body of evidence that above average FT4 levels in the upper half of the range are associated with the promotion of cancer and growth and spreading of cancer, acting on a cell membrane receptor. I don't want to go in too deep, but it seems to me it makes sense for thyroid cancer patients to offer them combination therapies so that they can achieve the same TSH with a lower free T4 and a normal free T3, that we're putting people at unnecessary risk by giving them a free T4 that is in the upper half of the range.
Yeah, so I'm aware of some of the evidence. I don't think it's consistently proven, and it's certainly not proven enough for us to give everybody combination therapy with T3 and T4. But there are indeed a number of thyroid cancer patients who are on combination therapy. But I don't think the evidence is strong enough. I do not believe the evidence is strong enough, nor do my colleagues, to give a blanket T3, T4 to all patients with thyroid cancer.
But to some?
We do give it to some. It's generally based on patients who don't feel well on
I see.
levothyroxine monotherapy, not based on their risk of additional cancer.
Okay.
Thank you for your question, Jim. I'm just going to run through some of the ones that have come through on the chat, if that's okay with you, Kristien.
Sure.
I shall go and try to go and so we've had a question saying, what follow-up should I expect following total thyroidectomy for follicular cancer stage 0 low risk?
Not aware of any stage 0, but a low risk cancer treated with a total thyroidectomy. In my algorithm page, I would say that most centers will follow that up for 2 to 5 years. I presume total thyroidectomy not associated with radioactive iodine. Generally, in my center, that would be an ultrasound at 6 to 12 months, one at 3 years, and thyroglobulin monitoring. Often patients will be monitored in a nurse-led clinic, and between 2 and 5 years, patients will be discharged back to the GP, and their serum TSH target will be below 2, but within the normal reference range.
Great, thank you. Are some centers still using thyroid hormone withdrawal before radioactive iodine? Is it not possible to use thyrogen routinely?
So most centers do use thyrogen routinely. There was some concern in patients who have quite big cancers, so T4 tumors that are quite advanced at presentation, that using thyrogen may not be beneficial, but the more recent data show that this is good. I am not, of course, work in a big center, but in my center, I do not know of a single patient in the last 5 years who's had thyroid hormone withdrawal and not thyrogen.
And what is the definition of advanced thyroid cancer currently?
That's a very good question with a difficult answer. So even if we talk about radioiodine resistant thyroid cancer, so like I said, thyroid cancer, the differentiated thyroid cancer is treated with surgery if it's sufficiently aggressive with radioactive iodine. And then if patients have cancer that still continues to grow or that spreads to other organs, sometimes it becomes resistant to radioactive iodine. Certainly that would fall into an advanced thyroid cancer stage. Cancers that have metastasized to lymph nodes and to distant organs would also be classed as advanced thyroid cancer. So it's something that not everyone defines in exactly the same way. And even if you look at a definition of a radioiodine refractory, so resistant to radioactive iodine thyroid cancer, that is not a consistent definition used throughout the world.
Thank you. For someone who's considering thyroid, for someone who's considering thyroid surgery for thyroid cancer, what is the risk of post-surgical hypoparathyroidism and voice changes?
Okay, so this, number one, depends very much on the surgeon you have, and number two, depends on how aggressive your cancer is. Because if your cancer has already invaded the vocal cords, then you may have voice changes. If there is a lot of lymph nodes involved and the surgery is more extensive, then your risk of getting that is higher. But there is a very clear correlation. So the more operations your surgeon does, the lower the risks of all these things are. And all surgeons are required to put their data, publish their data. So generally, the risk of getting a number of patients get temporary voice changes and temporary calcium problems. The risk of permanent voice changes and permanent calcium problems are in the hands of good surgeons or excellent surgeons are in the order of 1 to 2%. But up to 10% can get temporary problems with calcium, and certainly up to 5% can get temporary problems with voice changes. But it very much depends on whether the surgeon has to go into the central compartment, whether there is a lot of extensive surgery, and whether that original tumor was actually already invading certain structures, in which case that makes the situation much more difficult for the surgeon and therefore the risk higher.
Thank you for that one. To what extent are TC patients being tested for molecular markers that may identify advanced thyroid cancer?
So this is an area where the UK is actually quite behind many other places. So certainly cancers that progress, be that differentiated medullary or anaplastic, those patients get molecular testing. So you can use molecular testing to diagnose thyroid cancer or to help diagnose. So in those patients, I told you, those patients have a nodule that's indeterminate, where, you know, the pathologist says it's a follicular lesion. I don't know whether this is cancer or not. So increasingly in the US and in Europe and in the Far East, they're using molecular tests to help refine that. So that's one way of using it. But there's then also a way when a tumor is removed to predict what is the molecular makeup of this tumor, and therefore how aggressive is this likely to behave. And that's where we're lagging behind. But increasingly, we are doing this now, and certainly in patients who develop disease that continues to grow or that continues to metastasize, that's where we start using that more and more.
Okay. We're going to go to Mike again, because I think he's tried it on a different device now to see if he can come to you. Do you want to
Mike.
Okay. Hi.
We can hear you properly
Kristien. Yeah. Hi. So with me, so I had my diagnosis and a year ago, and I had total thyroidectomy and a neck dissection on my left side. Now, I'm going to be honest, I regret the surgery, because reading my pathology report, I found that I had 2 tumors on my left lobe of my thyroid gland and not on my right lobe. However, and there may be a bit of malpractice going on, because my oncologist, when he writes his letters to my general practitioner, he often writes that I had a tumor in a 7mm tumor, follicular variant PTC on the left lobe, and then I believe he writes an aggressive T cell 4mm in my right lobe. Personally, I do believe I should have the lobe endectomy, but I just want to ask you that, given that my tumors were less than 2 centimeters in size, wouldn't it be best that I possibly be given more of an active surveillance treatment to avoid, you know, going to the traumatic step of surgery, or maybe to be offered the RAI instead of surgery? An older patient, especially over here in the UK, they wouldn't be seen as being able to possibly survive the surgery. So usually they are offered some treatment rather than surgery. Because I'm younger, I was offered surgery instead. But I don't know.
Do you mean RFA treatment, radiofrequency ablation?
No, RAI, radioiodine.
You couldn't give radioiodine to someone who hasn't had a thyroidectomy. You cannot give radioactive iodine to someone who hasn't had a thyroidectomy for thyroid cancer, because it will just all be taken up by the normal thyroid gland that surrounds your small tumors. So you need surgery first before you have radioactive iodine for thyroid cancer. So that is not an approach that anyone uses. There are some centers now that for those microcarcinomas, which is what, if you had a 7mm and a 4mm one, there are now some centers that are using radiofrequency ablation. So essentially in that little nodule, they put in a probe and they zap it, for want of a better word. But you wouldn't get radioactive iodine, and that wouldn't work without doing surgery. I can't really comment on whether you should have had the surgery or not, because, you know, I haven't got all the information there. This is a decision that's made, and I was talking with Judith about this. This is a decision that's made as part of a multidisciplinary team. So every week, every Wednesday morning, I go to the multidisciplinary team meeting. We look at the images, we look at the cytology, and we have the endocrinologist, surgeon, oncologist, radiologist, pathologist. We're all together there, and we make that decision. So I'm afraid I can't really comment on that, because I don't have all that information and I'm not in that setting. And I'm sorry that you regret your surgery and that you don't feel well. So like I said, a number of centers do active surveillance. If there is suspicion of a tumor on both sides, they may not. It's often for a single small tumor on one side that they do that. But, you know, like I said, that's all I can say about that, really.
Thank you.
Thanks, Mike. Just a couple more questions, and then I think we'll call it an evening, because we appreciate you taking up your time on a Sunday, Kristien. One of the questions is, what is the risk of weight gain, and can it be overcome? I'm assuming that's probably post-surgery.
Yeah. So weight gain in patients who have thyroid issues is a big interest of mine, actually. So I have a big interest in that in patients who have treatment for hyperthyroidism, where again often they're made hypothyroid. And so in the hyperthyroidism field, we expect patients that they will gain weight, they will have lost weight before they present, so they will regain. Patients who become hypothyroid do seem to gain a bit more. Generally, when you look at that in absolute terms, there isn't actually, you know, in absolute terms that much in it, but it would appear that a hypothyroid state does make weight management more difficult. So the main issue here is that adequate replacement is given, and that so the evidence shows that patients who follow a healthy lifestyle, that generally weight can be better managed there. But you know, it is a problem. I accept it. I don't think we fully understand all the homeostatic and changes that people get when their thyroid status changes from having a normally functioning thyroid gland, which is what most patients with thyroid cancer, their thyroid is functioning normally, to actually making them hypothyroid. I don't think we fully understand, and I think we have a lot more to learn on that.
That's great. There is a question coming in saying, patients are given T3 after thyroid cancer treatment to suppress TSH. Can any problems arise from suppressing THase then? In hypothyroidism, doctors advise avoiding suppressing TSH. So are there any risks if the T3 and T4 are not too high, if it's okay after thyroid cancer? It seems confusing.
Okay, so the reason why we do it after thyroid cancer is because TSH drives the growth of thyroid cells. And it's, in medicine, it's always a risk balance. Everything is a balance of risk. So here is a patient with thyroid cancer. Those patients where we still suppress TSH are patients who have aggressive and relatively advanced disease. So in those patients, the risk that thyroid cancer causes problems, kills them, is higher. Okay, that is different to a patient who has hypothyroidism or who has a low risk thyroid cancer, who has a very long life expectancy, where we know that suppressing TSH is associated with significant risks of heart disease, osteoporosis, dementia. So it's the risk balance, and that's why in patients with aggressive thyroid cancer, it's okay to suppress serum TSH. But even in those patients with aggressive disease, we tend to do that for a limited period of time, because if they respond well to treatment, they will move into a different risk category. So that's the thing of dynamic risk stratification. You can go from a high risk group to an intermediate or a low risk group if you respond well to treatment. And then you will come in that category where we no longer do it, because we feel actually you're now in a situation where the risks of suppressing it outweigh the risks of the cancer coming back. I hope I've sort of explained. Yeah. You know, it is that balance that we have to address, and every disease, or most diseases in the that we currently treat, are very much an individualized decision making. But I think this is specifically true in thyroid cancer, where what works for Jim may not work for Jenna. And it's very individualized decision making. This is what's right for this patient based on how the patient feels, what their disease was, how they have responded to treatment. And that is different.
Yeah. And these are the last couple we'll just go through. Is it guaranteed that you will go hypo after you've had half of your thyroid removed?
The chance is about 20%.
Okay, excellent. Is TGAB an indicator of cancer?
So thyroglobulin antibodies. So this is interesting. So thyroglobulin antibodies are present in patients with autoimmune disease, and they're present in about 10 to 15% of the population. If a patient didn't have thyroglobulin had the thyroid removed, didn't have thyroglobulin antibodies, and suddenly develops them, well, they shouldn't develop them because they don't have the thing to which antibodies should develop. So often that means that there is some disease present. So antibodies that suddenly develop after someone has had full treatment and had their thyroid removed, and we think there are no thyroid cells here now, and they get to develop those antibodies, that's an indication to me, hang on, something is happening here. There is something happening to this cancer, because why should these antibodies develop? So we can follow them. They make our interpretation of the actual thyroglobulin level very difficult, but they're also an indication that something may be happening that we certainly don't want in patients with thyroid cancer.
Okay. And the last one is just going back to Becky, who put a question on earlier because she's had a total thyroidectomy. And she's saying that she's currently on 100 mcg of levothyroxine, and she's been on that following her TT 8 months ago. Her levels are deemed within normal range. Other levels are fine. Why does she feel so dreadful? Her PTH is low. Would that be it?
So PTH could be low because of the surgery she's had. So yes, hypoparathyroidism does make people feel dreadful.
Okay,
so something that needs to be addressed by her physicians.
Yeah, I was
to
going to
see
say
whether that's the cause and possibly optimize her levothyroxine replacement would be my suggestion.
Okay, excellent. Sorry, just the last one, because I know Jenna's quite desperate. Jenna's been struggling. Just to clarify, her TGAB was found before the cancer. Was that an indicator? I think
no. That just means that you have antibodies to thyroglobulin, which, like I said, occur in 10 to 15% of the population. So many patients with thyroid cancer have a degree of underlying thyroid autoimmunity. There is a link there.
Okay.
But that's what it reflects, thyroid autoimmunity.
That's great. Thank you. Thank you, Kristien. Thanks for answering all those questions. I hope that's helped everybody this evening. And I'm just going to stop recording now and thank everybody very much for coming. And in particular, you, Kristien, for giving up your Sunday evening. And hope to speak to you all again soon. So take care. Enjoy the rest of your evening.
Have a nice evening. Bye-bye.
Thank you.
Thank you, Kristien.